And we are back, and this is How You Livin' on the Edge Radio Network. I am here with Dr. Kiva. This has been such a cool conversation so far, and it's about to get incredibly informative, and I think may upset a couple of people.
Yeah, and may upset me.
Yes. Yeah. So you are familiar with what this is all about, and we have Miss Umi, right, that's going to be joining us.
Mm-hmm.
I'll let you introduce her. Can you hear us? Hi.
Hey. Hi, how are you? Can you hear me?
We can. Thank you for coming on the show.
Of course. Thank you for having me.
Wow.
So could you tell us a little bit about yourself?
So I am an attorney. I call myself a joyful warrior. So I'm an attorney, I'm an advocate, and I work in policy here in the city of Chicago. But I grew up in Houston, Texas. So I'm missing Texas, and this is making me feel at home.
Well, Umi, I would like to put you in a sauna, and then you would feel at home, because in Houston right now it is 96 degrees and about 90% humidity. You remember those days?
Feel like temperature.
I remember those days. I
hardly think Chicago is quite as humid, but nonetheless, I'm glad you're a Houstonian. You can relate to it. But it sounds like, as a joyful warrior, you have been fighting the fine fight.
Yeah, I mean, so I like to talk about my story I call it my path to being empowered. I was actually working as an assistant state's attorney, which is a prosecutor here in Chicago in 2018, but I had been experiencing pain consistently over several years. And so I had great health care, I had a great career, and yet I was still in pain. And so when I ended up going to the doctor, it was one day after I had been I had been in so much pain, essentially, that I was crawling on the floor to get to my remote control. So I go to the doctor, and I'm basically asking the doctor if what's wrong, and she told me that nothing was wrong and everything seemed normal. And I didn't believe her at this point, because I just knew that it wasn't normal for me to be walking around, like crawling around literally in pain. And so what I did was I did what doctors tell you not to do. And I went to Google and WebMD and Googled my symptoms. And it turned out Black woman, 30s, and with my symptoms, that it was clearly fibroids. And so fibroids are non-cancerous tumors that grow in the womb. And they happen in 70% of women, but in Black women, when they happen, they tend to be younger, they tend to be more numerous, they tend to be larger, have more severe symptoms. And in the book, I say, check, 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 and check. So I ended up going to someone in my network, a specialist, and I told her that I had fibroids, and she confirmed it. At first, she saw 3. And then we had an MRI where she saw 22. And when I went into surgery, they found out that I actually had 30 and ended up removing 26 of them. And so I just thought, this can't be just me, right? This must happen in other women. And I was right. I started to talk to women in my circle, women beyond my circle. And you just keep getting these stories of your pain being dismissed, doctors not believing you. And I decided that I was going to do something about it by writing this book.
Wow.
Your story reminds me of Serena Williams' story. When she went, she had her child, and then after, she went home and she couldn't breathe. So she went back to the hospital to say, well, I can't breathe. And I was like, oh, well, don't worry about it. Just take some medicine. You'll be fine. But because she insisted, they decided to do some diagnostic testing and saw that she had blood clots in her lungs. Wow. And that's why she couldn't breathe. And so she had to go through and get that taken care of course. But the fact that, why don't doctors listen to women or listen to anyone when we tell them that something is wrong and we know in our spirit that it's wrong? What is that about?
So, I use a lot of stories to explore just that. What is the root of that dismissive treatment? What is the root of where does that come from? Because you hear that a lot in women, and it's not just Black women, right? You hear that a lot in women about the idea of being dismissed. And I think that it is a combination of things. I think one of them is you cannot overlook the role of systemic racism and implicit bias, right? Everyone has a bias of some sort that they carry with them. But the difference is when it's in the medical community, if those biases impact the kind of care you give, then that's when it gets dangerous. So when you think about in the context of, look at the fact that in 2016, there was a study where they found 40% of medical residents believed that Black people had thicker skin, making them more impervious to pain than white people.
Wow.
And so when you start thinking about that, yes, and this is medical professionals that they were residents, and it was 40% of medical residents in the study that were surveyed that actually believed that Black people were more impervious to pain. In fact, there were other completely, I think what's a little frustrating is easily unproven fallacies that they believed, right? But then you look at the statistics, and Black people are less likely to receive pain medication when they complain of the same or similar issues as their white counterparts. So if you even take gender out of it, you realize that there's this issue here where there is the element of systemic racism and implicit bias. And that is, I believe, impacting the level and the quality of care that people are receiving. You see that Black women, when they ask for pain medication, sometimes are seen as drug seeking. And that's with a report that was out of the Illinois Department of Public Health, that a lot of times Black women are seen as drug seeking when they ask for pain medication. You also see that Black women are 3 to 4 times more likely to die in childbirth than their white counterparts. And you have not only Serena Williams' story, where she was telling them that something was wrong and they told her that everything was fine. Serena Williams is a millionaire, right? And so you would think that they would listen to Serena Williams. There's another story of a woman named Kira Johnson who had a routine C-section in California. And after she had the C-section, she was in pain for about 10 hours. Her husband asked for help. He claims that the staff told him, your wife is just not a priority right now. Wow. When they finally put her on the operating table, they found out that during the C-section, they had lacerated her bladder. Oh. And so she had been bleeding internally for 10 hours. And they found at least 2 liters of blood in her abdomen. And so when you hear story after story about this, you have to think about what is the root cause of it. And so I do think it's rooted in gender, because it is a problem with women. But I think just like everything else, there's that old saying that when white America has a cold, Black America has the flu. Right. I think that it is intersectional. And I think that the dismissive treatment just has an impact, just a visceral, you can see the impact that it's having on Black women's health.
Wow. So let's unpack a couple of things as we go along. But something that you said, there's one thing that you mentioned, and most people don't know this. So, for example, you were talking about this idea of pain and how people supposedly of color have a higher pain threshold. You know who has the highest pain threshold? People with red hair. Actually, this is a true story. People with red hair have a resistance to anesthesia, and they also have a higher pain threshold statistically than other groups of people. So freckles with red hair, highest pain threshold.
Ginger's got it.
That's right. Now, you were talking about drug users that are trying to get a hold of pain medications. Well, pain medications are abused more highly by our Caucasian counterparts than by African Americans.
And you know what's interesting, though, because of the bias that the medical community have, it was a story where they assumed a Black woman was on drugs because of how she wore her hair. Because they didn't understand culturally what that means. So it's like, okay, she must be a drug addict. Wow. Because I think a lot of times in the medical community, they assume that we are unhealthy. We have diabetes, we're obese, our muscles are dense, and maybe it looks differently for how we absorb medications. Yeah. So it definitely shows up. And it shows up also, like, if you have surgery, a black person is more likely to be released from the hospital in a shorter period of time than a white person. They keep them in the hospital a little bit longer.
None of this is making sense to us. So, Umi, you can help us unpack this a little bit more. We got to get to the root of why this is happening, but we're going to take a quick break.
And welcome back to How You Living on Edge Radio Network. So today we are talking with Mayumi Grigsby, and we're talking about the medical community and how they view people of color. And you know what's interesting, Uma, is that it doesn't matter sometimes about where you are as far as money, because money, education, you can be the same as your white counterpart and they still see you as someone who maybe doesn't need the medicine, or they treat you differently. So what are your thoughts on, you know, we talk so much about high rates of death, right? So it's murder or suicide. It could even be like cancer, diabetes. And so if you have these high rates of cancer, but you're not getting the medicine, is it really true that you're dying because of cancer or lack of treatment? Have you noticed that in any of your research?
Yeah, I mean, so I think people talk a lot, and one of the chapters I talk about is from the perspective of a Black woman who is a healthcare provider like yourself. And she talks, you know, and in that I talk about what a lot of Black healthcare professionals say that they overhear from their white counterparts, which is sort of putting the blame back on people of color, right? Well, she's not listening, or she's not, or it's because of the diabetes, it's because of pre-existing conditions, because of a lack of insurance, because of all these other things that, you know, people of color aren't doing. But then let's go back and think about why in some areas we don't have access to those things, right? So for example, if we use Chicago and we talk about redlining, where by design, by policy design, we've cut off certain areas from access to fresh vegetables, fresh produce, transportation, green space. And all of those, when you don't have access to that, that contributes to some of the factors that can lead to things like diabetes, hypertension, cancer, and a lot of these other things that you talked about. But then afterwards, when you're going in to get care, and you already have to muster up the courage to go in. You know, somebody I talk about in the book said that before she goes in to speak to the doctor, she makes a list of all of the questions. She tries to be very nice to her doctor because she thinks if her doctor likes her, then her doctor will be nicer to her. So you're already dreading going to the doctor, and then you go to the doctor and you have this kind of experience. So then how does that impact how willing you are to go to the doctor, how willing you are to share what's going on with you, you know, and how willing you are to enter into this partnership with a doctor who can really give you the advice you need to get better. And so I think that's why I want to talk about this dismissive care, is because people are also making decisions about their health when they experience dismissive care, because it doesn't make them want to go to the doctor. And not only that, there are some things that we don't know. Like take, for example, Chadwick Boseman. You know, there are certain forms of cancer that we've been taught we shouldn't worry about it until we're 40 or 45 or 50, right? But now they're finding out that these things happen earlier when it manifests in Black people. So whether it's breast cancer, whether it's colon cancer, all of those things we have to start testing for earlier as Black people. And if doctors aren't aware of those differences, if doctors aren't communicating that to us, if doctors are assuming that when we don't understand something, or they're not, you know, expressing it to us in a way that we understand, and we're not acting on it, that's somehow something wrong with us, then that's something we have to address.
You know, that's so interesting, because I've noticed as a chiropractor, when I'm talking to some of my patients, they'll ask me questions that I'm like, well, didn't your ortho tell you that question? And then I have to sit and explain it to them, but they feel comfortable enough to say, well, why is this? Right. You know, and so it's I see it all the time of, I don't know if it's it's almost like people are afraid to ask the doctor the questions.
But is there a case of people that say, well, I'm comfortable with you, you're a melanated woman, I didn't want him to think I was dumb?
I think
because
so.
I'm sitting there and I don't want him thinking less of me.
Yeah, and I want to create an environment where ask me anything. If I don't know, I'm gonna find out.
Correct.
But so they ask me, and I have to explain everything to them. And by the time they see me, they've already probably had surgery and the whole nine before they come to me. Wow. And I'm just like, we don't have a voice sometimes, or I don't know, I hate to say it, that slave kind of still thinking they don't feel comfortable enough to speak to the person who has the power, I guess.
Right. Well, so Umi, let me ask you this in relation to what Dr. Kiva is saying. Is there a difference based on your research with Black physicians versus white physicians and the level of communication, the standard of care, and this dismissiveness that you're talking about?
Yeah, there are studies that show that when you are taken care of by a doctor who looks like you, that your outcomes are better. And that's clear, in the research. That's not, me saying that. There's research that indicates that when Black patients are taken care of by, Black doctors, that they have better health outcomes. But then how can you have that if right now only about 5% of doctors, of active practitioners who identify as Black, there's only 5% of them, right? Mm-hmm. And if you're a Black woman, you're looking for another Black woman, that's only 2% of doctors that are working right now. And so even if that is the case, the problem now is there aren't enough for every, person to feel that they can be taken care of by someone who looks like them. And I think that there's another thing to be said. There is a lot of historic examples of mistreatment. When we talk about some of these, things that people think, you can go back to Dr. Marion Sims, who's the father of obstetrics and gynecology, who conducted experiments on Black women. And a lot of these sort of experiments, they people start to believe them the more you say things, right? And so then you have something in 2016 with people saying, oh, well, maybe Black people have a higher tolerance for pain. Or you think about Tuskegee and you think about the fact that the US government actually, did not tell these Black men that they were not being treated for syphilis over the course of about 40 years. So of course, you're going to be, if you know about this and you're affected by this historical trauma, is going to impact how you interact with a medical professional.
A total distrust. Yeah. And that even goes into COVID, how it affected the non-white community a lot differently, going back to poor immune system, not having good health care in the community, and then we had this high rate of death. Then we turn around and say, okay, now let's do a vaccine. But there's so much distrust that was already built, that we have a foundation of distrust.
Yes, you're right. So culturally, this thing runs really deep, because if I'm hearing you correctly, Umi, and you're in Chicago, which is a very large Black population, just like here in Houston, we have these disparities, and a lot of it has to do with lack of access. But let's go even further back. You're talking about food deserts. Mm-hmm. You're talking about this distrust that is endemic in our communities, that people don't want to communicate with their white doctors or non-Black doctors and ask them questions like they ask you.
Oh, wait, don't forget a poor infrastructure with pipes like lead that was in, so it's a lot of stuff built up on
that. So we're really dealing with a lot, because you're right, the crumbling infrastructure means that in most communities, in fact, I saw a report just this morning that was talking about how in communities water is horrible, and they're on boil alerts all over the country. Mm-hmm. Every 2 minutes a water main pipe breaks in the United States. I mean, is that insane?
And I don't know if you know this, Umi, but we have a community in Houston, what is it, Fifth Ward, that a lot of the people had cancer.
Yes.
And it was in that poor community.
Yes. And I think the same can be said about some of the industrial outerlying communities. So because we're experiencing that, Umi, based on this disparity, it sounds like this is going to be a multilateral approach to trying to rectify this. Is that true?
Yes, I think so. I think everyone needs to figure out what their part is in fighting this, right? And so there's something that I say in there that, you know, tap into your community. So that community involves not only your healthcare provider, right? And being able, because I honestly do not believe that anybody would go to school for as many years as you have to go to school to be a healthcare practitioner. It's very hard to go into that and to be a provider, especially during this time. We know a lot of our first responders were negatively impacted by COVID. And so I do think that, you know, there's good intentions. And so there's a role to play there, right? And maybe some people don't see it. And it's very hard for some people to hear when they hear about the implicit bias and the experiences of other people. There's a knee-jerk reaction to be like, well, that's not me. That doesn't apply to me. But we all have a role to play. So for example, if I'm there and I hear someone say, you know, oh, you're an attorney, I'm going to pay more attention to you. Like somebody in this book who said that, you know, there was a doctor that was like, usually if someone, you know, like you comes in complaining for about some of these things, I would just tell them, you know, maybe you're just tired, maybe you're just overworked, but I see you're a lawyer and I see that, you know, you're ambitious. So I know you're not making this up. And so, but your role there is to say, hey, that's not fair. Like you don't get to decide, you know, what kind of care I get just based on these things that that you assume about me because of these facts that you know. So I think that we have an obligation to tell our stories. I think we have an obligation to listen when other people tell their stories. And I think that healthcare providers and healthcare companies have an obligation to also, you know, see their part in it and figure out how there can be accountability. Wow. I think government also needs to step in and make sure that you know, this isn't happening. Because if you look at the context of COVID, we needed people to be able to trust the government and we needed people to be able to trust healthcare providers. And I can't help but wonder if the reason that we have these vaccine disparities and, you know, in Chicago is 68% of people in the beginning, on the onset of the pandemic, who were dying of COVID or contracting COVID were Black. And Black people only make up 30% of the population here. And I think that those numbers are replicated across the country. So when you think about the fact that we're now in a place where we were supposed to have this trust, and people are remembering all of the times that they've been let down, I think it's clear that we all have a part to play in ensuring that we build that trust, that we get rid of this sort of disparate treatment and different treatment based on race.
Yes,
you know, that's we're going to take a little short break, but when we come back, let's talk about how technology and the medical community could also have that bias when we look at technology. So we're going to take a little short break and join us for the rest of our discussion on the medical complexity in America.
Yes. We are back. This is How You Livin' here on Edge Radio TV, joined by the amazing Dr. Kiva Davis. And we are having a conversation about some of the disparities that are taking place. And we're speaking with Mayumi Grigsby, an attorney out of Chicago. And just before our break, Dr. Kiva, you were bringing in a couple of interesting points around technology. Mm-hmm. And I wanted to frame this a little bit, Umi. There's a Netflix series. It's not a series, it's actually just a documentary. And it's called Social Dilemma. And on this, they were showing that it was a young African-American woman, and they were using facial recognition software. And they were saying that her face was not recognized 14% of the time because the algorithm was set towards white males.
Right.
So any melanated person, a female, literally was not recognized by facial recognition. But now why that's problematic is because it factors into all sorts of other places. For an example, credit worthiness, where somebody lives, what medications, what processes, what the standard of care is. And that goes back to something that you were asking. So to the extent that you've done this research, Umi, what type of effect has the technology that has now been incorporated into these algorithms fit into the biases that we're seeing in the disparity that we have in healthcare?
So, I didn't go into that in this book. I can say that I remember reading a couple years ago that apparently, the technology when you're going to wash your hands, where you have to put your hand in front of the sensor, that sometimes it doesn't recognize your hand when you're a person of color, when you're darker skinned.
You gotta be kidding me. Now we can't even wash our hands. That's some bullshit right there.
No wonder I always have to do this over and over
reading
again
that and thinking to myself, well, that's a problem.
I gotta put on a white glove just to get the faucet to start. Now you talk about cotton picking days are over. No, I'm sorry. I digress. Go ahead, Jen.
There have been all these stories recently where you talk about, AI in the criminal justice context, right? Where you can't really trust it all the time when it happens to be about Black defendants, right? Because it hasn't necessarily, the technology hasn't gotten to the point where it can be used to correctly identify people of color who commit crimes, right? And so it leads to those kinds of issues where you can't really rely on that when you're using that to as evidence for conviction. So I think you have to look at who is developing this technology, right? Because people will develop technology, and people will do work from their lens, from their perspective.
Right.
And so if the person who is developing the technology is not a person of color, then they don't think about things like that. It reminds me of a story somebody told when I was talking to a Black doctor, and they were saying how, for example, one of the tests, I think, in babies is whether or not the baby's lips turn blue. Mm-hmm. Well, if the baby is an African-American baby, is that going to be as obvious if the lips are if their lips are turning blue, right? And so I think that we need to start thinking about, culturally competent care and looking at factors that actually speak to the individual nature of all of us and the diverse nature of all of us. And that means that we need more people of color developing technology, more people of color testing technology, more people of color, basically at all levels, because that's how you actually have tech that works, that is inclusive, and that, is accessible.
Well, it's interesting because under President Biden, the CDC is now saying that it's a problem, that racial disparity in medicine is a problem. Have you noticed any policies that they're going along with this? And what group are they looking at? Is it just looking at poverty levels, or is it looking at something grander that they're actually doing anything for with the CDC?
Sorry.
Oh, no problem.
I am actually very encouraged by some of the policies that are being considered around the country, not only at the federal level, but also I think in different states. For example, in California, I talked about the Black maternal mortality rate and how Black women are 3 to 4 times more likely to die than their white counterparts. In Illinois, it's 6 times more likely. California has the lowest maternal mortality rate in the country. And yet Black women are still dying at 3 times the rate of their white counterparts. And so what California is doing now is introducing legislation that calls out implicit bias and the role of implicit bias, and mandates training around implicit bias. In Illinois, we just passed some legislation around that, where now we're, it's not only implicit bias training, but it's also developing advisory councils that can look in and root out, the instances of implicit bias, right? There's a race commission, essentially, that's going to be providing advice. But then also I see legislation coming out about looking for things that, are prevalent within Black women, right? Like, for example, hypertension and diabetes, and thinking about that and educating people around that. I think that, Vice President Harris had that as part of her, her mandate. And I do think that with the CDC at least being willing to consider that racism is a public health crisis, and being willing to acknowledge the role that systemic racism plays in this, I think that we're going to start getting a lot more attention to health equity in general. I know the American Medical Association is now also looking at an equity plan. So I think the good thing is that we're at a point where people are at least willing to acknowledge that this is a problem, and to start to look at it holistically. You know, in my mind, I do think that there's a variety of issues. Like, it starts from underinsurance, right? But then we have to look deeper than just like, okay, we get everybody on insurance. You also have to figure out what the quality of care is, because if these disparities exist regardless of income level, education level, whether or not you have access to quality care or quality insurance, then it goes deeper, and you have to go at the root of systemic racism, which is, the implicit bias and making sure you have culturally competent care.
Wow.
I personally think they need to have some kind of class or in the curriculum at medical school on understanding different ethnic groups. Yes. and being respectful to those, because if your first thing is to do no harm but you're not giving someone medicine, it kind of doesn't go hand in hand.
Yeah, it makes no sense. And the fact of the matter is, I'm glad you were saying, Umi, that legislation is being passed, because if you look at 2050, 30 years from now, or 29, it's going to basically be a dominant melanated skin-colored nation by then. And if these biases have not been addressed, that means that disproportionately there is a growing number of people that are going to be dying or sick, or unfortunately the diagnosis may not be as good as that of their white counterparts. So in the few moments that we have remaining left, Umi, what can the average person do to address this issue? Because this is a real problem and it's happening everywhere in the country.
So I think that it's about accountability, and how do we make sure that we're holding people accountable? So, for example, one thing that I do is I go to a federally qualified health center. And the reason I go to a federally qualified health center, even though I have access to, Northwestern and all of these amazing, private institutions, I go to a federally qualified health center because these are community-based centers where their funding is tied to the quality of care that they give, right? They are governed by 51% of the people in the communities that they serve. And so a lot of their focus is on how do you give culturally competent care. And so for me, it's always been important to vote with my dollars. Like, I support Black-owned businesses, I support, how empowering women, I support empowering, marginalized people. And so for me, it's, if you are doing the work, if you are active in your community, if you are working on the implicit bias training, if you are telling me how you're going to address these disparities and acknowledging the disparities, then you get my support, right? But that's at kind of like the national level. But what can you do as a person when you go in and you see these things, or you have to talk to a doctor? You can say, listen, I understand that you're busy. I understand that you are the doctor. I respect your expertise. However, you're not addressing my problem. I came here because I'm in pain. You may not believe it. You may not think that pain is a lot, but I'm going through it. I'm experiencing it. I know my body, and I know that this is what's happening to me. And so I need you to work with me so that we can find the root cause of what's going on. And I think if more people start to advocate for themselves in that way, and if more people believe those people and provide them with the support, I think slowly but surely we will start to create a community of change makers. So I believe in the power of storytelling. I think that we should share our stories. I think we should affirm other people who share these stories of disparate treatment. And I think that we should call it out when we see it and support, data-driven, proven, evidence-based solutions.
Yes. Wow, fantastic. So we've been talking with attorney Miss Mayumi Grigsby. Thank you so much for joining us from the cool and not so humid Chicago.
And
but
also how can people get a copy of your book?
That's what I was just about to ask. How do we stay in connection with you? Tell us, please.
EmpowHERed Health is actually on it's on Amazon right now, but I do have a website. It's mayumigrigsby.com. So it's UMI, Grigsby is GRIGSBY. So it's very easy, mayumigrigsby.com. You'll see how to get this book, and not only this book, but I'm also in the latest version of Chicken Soup for the Soul, which is it's 101 stories from Black women. So it's Chicken Soup for the Soul. I'm speaking now, and so my book is available anywhere books are sold, and you can also keep updated at mayumigrigsby.com.
Awesome.
I'm already going to sign up.
Awesome. Umi, thank you so much for joining us. This was a great conversation. Please, folks, share this information. As you said, Umi, we can only beat this if we address it as a community. Thank you so much for joining us.
Thank you.
Wow. Well, folks, thank you. You've been listening to the Edge Radio Network. Go to Edge Radio TV, connect. And this has been a joy being able to co-host with you. And in accord with your tradition, I guess we have to ask the question.
We do.
How you living?